Hey, a promise is a promise. A deeper dive into headaches and how to avoid misconceptions about migraines. Welcome back to Headaches and Migraine Management, Part 2. I'm Mary Windishar, and here's how to make the most of today's interactive session. Ask anything at any time. Just type your question into the Q&A box on the lower right side of your screen and then click Submit. You can customize your slide area by clicking the Maximize icon at the top right of the window. Now, if the volume's too low, try adjusting the sound level on the media player. Need closed captions? Just click the CC icon to the right of the media player. If you're having any technical difficulties, please click on the question mark icon. And today's slides are available in the Resources folder. Finally, please answer the feedback questions in the window on the bottom left of your screen. And now onto the presentation, Headache and Migraine Management, Part 2. Joining us today, and back by popular demand, I might say, Dr. Meredith Barad. Look at that camera right over there. Okay. And she's a board-certified neurologist and headache and pain physician. Her primary focus is head and facial pain. She's helped create a cross-disciplinary headache center and is the co-director of the Stanford Oral Facial Pain Program. And she's also the program director for the Pain Fellowship. Welcome, Dr. Barad. Glad you came back. Thank you.
Thank you. Thank you for having me. So let's get started. I wanted to set the stage. I know that some people want to go deeper, but in order to go deeper, we're going to just try to create a good basis of understanding of migraine for everybody who's participating in the webinar today. And I'm happy to entertain any and all questions so that we can really do a deep dive into what is migraine, why am I having one, and what can I do about it. I want to start with a definition, and I want you guys to think about migraine as an inherited disorder of sensory processing. Sensory processing is the way our brains process light, sound, touch, smell, and pain being a sensation. And so we're going to think about this as an abnormality in how the brain is processing sensation. I'm going to skip over that slide because we're going to come back to it later. But the criteria for migraine diagnosis, just to refresh everyone's memory, is that we want to have at least 5 attacks lasting 4 to 72 hours. These are long attacks. They're not brief. And they include unilateral pain at onset, a pulsatile quality to the pain, moderate to severe pain, aggravation or avoidance of routine physical activity. And then usually they are accompanied by 2 out of the 3 in this little column, photophobia, phonophobia, nausea, and or vomiting. And there's no other attributable diagnosis. So those are the basic criteria that we're working with. There's a lot of other features to migraine that indicate sensory amplification. Over 90% of patients have light and sound sensitivity. 70% of migraine sufferers have dizziness or vertigo at some point, maybe not with every migraine. 70% of migraine patients have visual symptoms, and we'll talk a little bit more about that. It could be a visual change that occurs prior to the onset of the headache, but also during the headache. They can have blurry vision, or sometimes their eyes kind of drop a little bit, their eyelids drop a little bit. We call that ptosis. Sometimes they can see different colors. 30% of patients have smell sensitivity. 75% have neck pain, which is really an important feature to recognize that is associated with migraine. 40% have sinus pain or pressure, and 50% have tearing, red eyes, runny nose, facial swelling. We call those autonomic symptoms. So this should be misconception number 1, but let's hit a misconception and then we're going to talk about it. It is commonly but incorrectly assumed that sinus or tension headache are more prevalent than migraine. But in reality, migraine is often underdiagnosed and mistaken. And so many patients will come to me and say, no, I don't have a history of headaches. I get a headache every time I get a sinus infection, or I get tension headaches, but that's just normal. And actually, that's not really normal. The majority of people do not get headaches. I have many patients who've never had a headache in their entire life. So a sinus headache or a tension headache, these little headaches that often are sort of overlooked and pushed aside. Sometimes when we think about them in the bigger context, when you are getting headaches frequently, more than once or twice a week, that could indicate that there's something more going on, that there is a migraine, an underlying migraine condition. Other features that I think are important is that migraine can change. So people sometimes say, well, I have my migraines, but now this headache isn't a migraine because it's on the other side of the head or it's in a different location. So migraine changes in position, and we don't think twice about that. That's very common. And the median time to peak intensity for most migraineurs is an hour. So it sets on pretty quickly, but the median duration is 24 hours. So oftentimes these headaches last a very long time. Headache can also occur at any time of the day or night. It can occur most commonly in the early morning hours, like 3 a.m., 4 a.m., 5 a.m., or shortly after rising in the morning. And migraine really does affect everybody. So you probably know somebody who has migraine. It's present in 1 in 4 households, 14% of adults, 18% of women, 10% of school-age children, 6% of men. Is a very common condition. Misconception number 2 is that it's underestimated as a minor health issue, but it is one of the leading causes of disability and lost productivity worldwide. So don't brush it aside. Headaches can be treated. Headaches can be changed so that you don't have to suffer and don't have to think that this is just a nothing. We can do something about it. So this is just a big slide with a lot of genes hidden behind here to let you know that we don't quite have it narrowed down to one gene. It seems like migraine, or the association of migraine with a gene or an allele is multiple. There are multiple different genes, and we don't quite have it narrowed down yet. But we do know that migraine runs in families. So if one parent has migraine, you have about a 30% chance of having migraine. Same with if 2 parents have migraine, it's a little higher. It's about 70% chance of having migraine. All right, so migraine can be broken down into 2 categories, episodic and chronic. Episodic means you're having less than 15 headache days per month, and chronic is more than 15 headache days a month. And it's a little bit of an arbitrary dividing point, but we do see that there's much higher rates of disability and depression in people who have chronic migraine, and that's probably due to lack of effective treatment. And so we really want to get those patients into treatment as soon as possible. And making the diagnosis is the first step in acknowledging this challenge. I don't want to say disease, but this is a health challenge, and it can last a lifetime. And it is very important that you partner with a health professional to make a treatment plan. Another misconception, again, sorry it's out of order, but another misconception is that migraine is a vascular disorder. And many patients come to me and they're concerned that there's something wrong with their blood vessels because they're having headaches. And while there are some headaches that are the result of vascular issues, in general, migraine is what we talked about, this inherited disorder of sensory processing. And what happens when we get into a migraine situation is that we get increased excitability in the cortical and subcortical networks. And so if you think about the brain as a computer with lots of different networks that are running at the same time, all these networks kind of increase their processing power, and they amplify all incoming stimuli. So bright light seems brighter, or just general light seems brighter. Sounds seem louder. Touch, even light touch, can seem very painful. And so this amplification of sensory stimuli can take a while to calm back down again. And we're going to talk a little bit about what triggers it and what we can do to prevent it and what we can do to rescue when we get into a situation where everything is amplified. So breaking down headache, I think, is breaking down migraine is kind of interesting. And for those of you who suffer from migraine or have loved ones who have migraine, you may be aware of this timeline that before the actual pain, that there's this prodrome situation where patients can have irritability or depression, maybe food cravings, maybe sensitivity to light or sound, but they often don't have the actual pain yet. And then there's the period which we call the aura. Not everybody has aura, but aura does precede the headache, and there are sometimes visual disturbances, sometimes there's temporary loss of sight or other visual things that I'm going to show you. Sometimes people can get numbness and tingling on a part of their body. Sometimes they can get word finding difficulty. And then we get into the headache, and that's when you feel the throbbing, drilling, burning, yucky pain. But you can also get nausea, vomiting, congestion, sometimes anxiety, sensitivity to light and smell. So there's and neck pain. So there's a whole bunch of things other than just pain that go into this experience of migraine. And then we have the postdrome, which is a little bit like feeling hungover, this inability to concentrate, fatigue, depressed mood, and sometimes actually euphoric mood, interestingly enough, and then some just kind of decreased processing power. So I think we talked a little bit about this, the premonitory symptoms. These can occur hours or days before the onset of the pain. And sometimes if you can learn to recognize your premonitory symptoms, then you may be able to say that you're more vulnerable to a migraine and try to minimize known triggers. Like I said, about 30% of patients, 15 to 30% of patients will have an aura, a visual aura, sensory language disturbance that's associated, that comes before the headache, 5 minutes to 60 minutes before the headache, and then sort of lasts into the headache, maybe an hour or so into the headache. These aura symptoms can persist. These are some pictures that patients have put on the internet of some they've recreated their aura. Sometimes they see something like we call that a fortification spectrum, because it looks like a fortification wall that was built around old cities in the medieval ages. And then the little blurry vision spot with a little bit of different colors in the periphery, that's often a common aura that people experience. Most patients have visual auras. If you're going to have an aura, 90% of patients have visual auras, but some patients will have paresthesia, so numbness and tingling in different parts of their body. And again, some patients will have this expressive language dysfunction. They won't be able to get the words out, or sometimes they won't understand what you're telling them. And this is a complicated picture, which we can definitely dive into. But what I want us to take away from this picture is that there's a little bit of a feedback loop. We headache scientists haven't pieced together the entire feedback loop yet, but there is cortical or brain hyperexcitability, which leads to communication with the nerves, and the nerves lie outside of the brain. We call that the periphery. And so that cortical hyperexcitability excites the nerves, and then the nerves get excited, and then they send messages back to the brain through the brainstem. And so we get into this feedback loop that can be very hard for the brain to stop. And that's oftentimes where we need to make an intervention to help the brain break down, stop that migraine, and reboot, essentially. After the pain, there's the postdrome. That can last for about 12 to 24 hours. And actually, patients can be very vulnerable for head pain and sometimes repeat migraines during this point of time. So things like bearing down or moving your head around can really disrupt, can cause much more pain. You're much more sensitive to pain during this time. Some of you have requested to learn a little bit more about the subtypes of migraine. So that graph that I showed you was sort of a general migraine. Migraines, there are some subtypes of migraines that I think are useful to talk about. So there's a subtype of migraine called vestibular migraine, and that's recurrent episodes of vertigo or dizziness or imbalance that seem to be associated with migraine. Vertigo is that the room is spinning around you, and dizziness is sort of like you feel unsteady or imbalanced. Either one of those can be associated with migraine. The vestibular symptoms sometimes bother the patients more than the migraine. So oftentimes these patients will show up in the ENT doctor, the ear, nose, and throat doctor, wondering what's going on, why am I dizzy? And we have to kind of piece it together that it's related to the migraine and treat for the migraine. So we have a great system here at Stanford of dealing with that. We actually have a neuro-otologist, which is a really cool specialty, where you are trained in both ENT and neurology and kind of help with this subset of patients. We call her the dizzy doctor, and we partner with her a lot to help treat our patients and diagnose them properly. Menstrual migraine is a very common form of migraine. So many women will say, oh yeah, well I get a headache around my period, and they don't think anything of it. But sometimes that headache can be quite profound, and there are women that have just migraine around their menses. Sometimes they have migraine kind of roughly around their menses, maybe outside, maybe at the beginning or the end. But about 18 to 25% of women who have migraine usually experience menstrual migraine. And so there are some different ways that we can treat the menstrual migraine in addition to treating the migraine at other times of the month. Interestingly, the drop in estrogen that occurs when your period starts is what we think may be triggering migraine. And so those variabilities of estrogen that occur during menstruation, sometimes during pregnancy and during menopause, can very much trigger migraines in many women. And then just a little bit about pediatric migraine, because many of us have children who have migraine, myself included, and it will present with a shorter duration than adults. And it's more bilateral. So my daughter will get a really bad headache, but it will last for an hour, and then she's done. She's out of it, and she's ready to go back to whatever she's doing. Auras can occur in about 1/3 of older children and adolescents, typically preceding the headache by 5 to 60 minutes, which is pretty similar to adults. And pediatric migraine is common. I mean, prevalence is about 1 to 3% in early childhood, but really when they start to develop is in adolescence. So for boys, it's about 10, and then 10 to 14 is usually a hot period of time for boys, and then they'll kind of quiet down and maybe resurface again later in life. In girls, it's really sort of when they start to get their period, so 12 to early 20s is really hot period of time for most girls, and then hopefully we can get a good regimen going at that point in time where they can continue through the peaks and valleys of migraine during their life. So, how is migraine treated? And this is the kind of check boxes that I like to go through with all of my patients. I do like to talk about trigger minimization. I like to talk about lifestyle, preventive strategies, rescue strategies, and then extra bonuses. And so we can talk about all of those, and we can certainly go deep if anybody is interested. There are many different types of triggers, and it's different for everybody. And sometimes you can get really obsessed about what your triggers are, and it can drive you just crazy. But triggers are essentially a change. And so what I tell my patients is that it's really good to try to keep as regular of a schedule as you can. Go to bed at the same time, wake up at the same time. If you really love your coffee, maybe try to have 1 glass of coffee every day, Monday through Sunday. If you really love your alcohol, well, we have to have maybe a little bit of a different talk, but alcohol and migraines, it's tough. It's tough to do. Work on exercise because that helps you minimize your stress and optimize the way your brain works. There are some things that are unavoidable. Sometimes weather changes can trigger headaches. Sometimes your monthly cycle can trigger headaches. But the more you know and understand your triggers, the more you can be prepared to try to combat them. I think we talked a little bit about lifestyle, regular, and healthy, non-processed diet. I think there are like 10,000 additives in the U.S. food supply. And so when you look on the back of something that you buy in the grocery store and you don't recognize half of the ingredients, I can't really tell you if that will or will not cause a headache. So eating, what we do know helps is protein, not a lot of sugar, not a lot of caffeine, not a lot of alcohol. And so I encourage people to have a low-carb diet with healthy proteins and lots of vitamins from fruits and vegetables and not a lot of processed foods. Obviously, we all cheat sometimes, but that's sort of the goal. There are a lot of medications that we can use for migraines. And so when you go see your doctor will talk to you about starting some preventive medications for migraines. And many patients will come to me and say, well, I don't want to take any drugs. I just want to take something that's natural. And there are some natural herbs and vitamin supplements that we can certainly talk about. But I will also say that we're very lucky to live in an age where we have medications that can help us so that you don't have to spend 8, 10, 12 days in bed. Medications serve a purpose. They reduce the frequency, they reduce the intensity of the migraine so that you can live your life. You can go to work, you can do social events, you can go to your kids' soccer games. And so I would encourage people maybe to not be as afraid of medications. I think that they do really help prevent and decrease the frequency of migraines. They can also be helpful in other issues. So for example, if you had high blood pressure and you have migraine, your doctor will maybe start you on a beta blocker, which is a medication for both high blood pressure and for migraine. If you have some mood disorder, maybe you have a little bit of mild depression and maybe you're having a hard time sleeping at night and you have migraines, your doctor might consider something like amitriptyline, which is a tricyclic medication that causes some sleepiness, helps you sleep, treats depression a little bit, and is great for migraine. So the doctor will try to find a medication that could be useful for some of the other issues that you are working on. There's a lot. And the ones at the very bottom are the newest kids on the block, and those are called the CGRP antibodies and antagonists, and we're going to talk a little bit more about them in upcoming slide. One of the things that we do a lot of for chronic migraine is something called Botox, which you've all heard about probably for cosmetic reasons, but we use Botox for migraine, and we use it in a set protocol of 155 units. And that protocol has been shown to decrease the frequency and severity of migraine by up to 50%. So if you're having 30 or 20 headache days a month, Botox is a really good option. The way Botox works, we think, is that the small sensory nerves, where we put the injections, take up the Botox, and it quiets them down. It quiets down their rate of firing, so they're not sending information back to the brain, and then the brain can quiet down as well. As I alluded to in 2 slides ago, the calcitonin gene-related peptides are these newer migraine medications, and they come orally, but they also come in these monthly injectables, which I think is really nice for some people. Some people love the option of taking a monthly injectable medication that just stays in the periphery. So the thing I like about Botox and the thing I like about CGRPs is that they are essentially peripheral drugs. They are targeting the nerves. They are not crossing into the blood-brain barrier and not crossing into the central nervous system. So they don't make us tired. They don't make our brains foggy. And they have very few side effects. So this is a great option. And moving on, the rescue medication. So CGRPs and all the medications that we talked about are preventive medications, and it's the goal of a preventive medication is to decrease the frequency and the severity of your headache days per month. But when you do get a headache, you need a tool in your toolbox, and many migraine patients will tell me that Advil doesn't cut it, Tylenol doesn't cut it. So these medications are called triptans. They've been around for a long time, and they are great medications. They kick in about 30 minutes. They usually cut the headache down severely, if not stop it. And they come in a lot of different formulations, intranasal, subcutaneous, oral dissolving. Some of them last 2 hours, some of them last 6 hours, some of them last 24 hours. So we try to find one and tailor it to match the course of your migraine. The CGRPs also have some rescue medications associated with them. Ubrelvy and Nurtec are CGRPs, so from that previous class, but indicated for rescues. Triptans have gotten a little bit of a bad rap. So you might go to the pharmacy and pick up your triptan, your sumatriptan, and your pharmacist will tell you that this is unsafe if you have high blood pressure, or if you have any palpitations or any cardiac issues. Extensive clinical experience has shown that inappropriate selected patients, triptans have a very, very safe, very, very favorable safety profile. Sometimes pharmacists will also tell patients that they're at risk for serotonin syndrome with triptans. Again, it's a myth. Triptans have a little bit of serotonin, but in general, you're not using them with the frequency that they would even remotely contribute to serotonin syndrome. And another myth is that there's like one triptan that's the best triptan. There are lots of different triptans, and I think that doctors and patients work together to find the triptan that best suits the patient's needs. Okay, so we've tried some preventive medications. We've talked about rescue medications, and sometimes we need a little bit of an extra boost. So occipital nerve blocks are often used to break an acute headache. Like if you went to the emergency room or an urgent care clinic, sometimes they would block that occipital nerve. And sometimes we do it for chronic headaches, although it's a little bit of a more complex conversation that we can certainly talk about. But the idea here is that by numbing up one of these big nerves that send input back to the brain and excite the brain, if we stop that input, then we can decrease the input that's going back to the brain and allow the brain to quiet down, trying to figure out ways to disrupt the feedback loop between the brain and the nerves. An SPG block is another way that we can disrupt this feedback loop. And this is a strange looking thing that I'm showing you right now. It's a little catheter that goes inside your nose and squirts some numbing medication into the sphenopalatine ganglion, which lies behind your nose, essentially. That nerve bundle is involved in both pain and the autonomics of your head. And so quieting it down can also disrupt the feedback loop and can allow the brain to gain control of the situation. There's also a lot of really cool devices that have come on the market in the past couple of years. And I like them because they're not going to hurt you. There's like no risk associated with trying these. And some of them can be very helpful. They modulate different nerves. And by modulate, I mean they try to regulate the signaling pattern of a nerve. So when a nerve is really unhappy, it starts to fire really rapidly. And then it transmits that rapid signal to the brain, and your brain interprets that rapid signal as pain. But if we could modulate the way that nerve is signaling, slow it down or quiet it down, then it's sending less rapid signal or less powerful signal to the brain, and your brain stops interpreting the input as pain. And these are different devices which we can go over, but a lot of them that's their goal, is to try to help with the modulation of some selected nerves. And these are different gadgets that my patients have told me about over the years that can help them in various ways. So the center one is the ice cap or the ice shade. My patients really love this when their head is throbbing and they take it out of the freezer and they put it on. They do take their rescue medications, but it kind of soothes them until they can get their rescue medications start to kick in. The ear one is one of these acupressure devices that some of my patients have told me is helpful. The eyeglasses are a red tinted lens, and different tints of color can be soothing to the brain. And the red tinted lens and the green light, so we call that red tint ox blood, and that green light in the upper corner of there, that is also considered to be a very soothing wavelength for the eyes and can decrease that sensitivity. And then a lot of patients ask me about food sensitivities. They will go to allergists and maybe get a big test that tests for mold and different allergens. But these online food sensitivity tests, they send you a packet, you give them some blood and send it back. Sometimes they can be enlightening and may help you avoid a few foods that might be triggering you more than you realized. We have some great resources in the United States. The National Headache Foundation and the American Migraine Foundation are excellent resources for learning more about migraine. They have a lot of in-depth articles about that. They have links to lectures and conferences and different patient questions. So I think those are both great resources. I would highly encourage you to look online and check those out. And oftentimes people ask me, how can I support my loved one? It's hard to have a loved one with migraine. They do need a lot of support at home. There's a link here to an article, 5 Ways to Help a Friend or a Loved One Who Suffers from Migraine. Those websites also have some information about how you can help your loved ones. And I think that it's also important to remember that just with any caregiving role, you need to also make time for yourself and make time for your needs so that you can be a better support system at home. All right, so in summary, before we hit the questions, we're going to have a lot of time for questions. Migraine is more than just pain. It's an inherited disorder of sensory processing that causes hyperexcitability in networks. And I think of it as a network disorder. It's also a feedback loop between the cortex or the central nervous system and the peripheral nervous system where the nerves lie. And disrupting that feedback loop and calming down that feedback loop is a big part of how we try to tackle migraine and treat migraine. And we can treat migraine by optimizing our network. So things that we can do are try to avoid or try to minimize our triggers, support our brain, and support the optimization of our brain function with a healthy lifestyle and regular exercise, and utilize medications and procedures, and I call them gadgets, those external neuromodulatory devices, to help quiet down the excitability in our system and restore the network to normal function. And here's a very tiny bibliography, but you guys, when you can download my slides if you want to see more articles. All right, I think.
Thank you so much,
Okay.
Dr. Barad. And now we'll move on to the question and answer portion of our event. To participate, all you have to do is type your question into the Q&A window. And if we don't answer yours today, as you see, we put together a whole other webcast because we didn't get to all of them, but we will reach out by email if we don't have another event. So please remember, our guest advice is for the general population, so consult your own physician for advice for specific stuff for you and your family. And by the way, if you'd like to see this webcast again or share it with a friend, just click on the same link that got you here today. So now we can move on to the questions. Let's go ahead and take a look at this one. Is sumatriptan safe for folks age 60 and over? So this person says it works great for me, but my mom's doctor said people over 60 should avoid taking it.
Yeah, that's one of these myths that I think sumatriptan gets a bad rap. So the triptans cause a little bit of blood vessel constriction. If you have had multiple heart attacks and you have multiple stents in your heart, then that small amount of constriction could be hard on you. But for the average person, no, it's fine to use. And so I do monitor my patients as they get older. If I have a patient on sumatriptan and suddenly they have a heart attack and they get 2 stents placed, then I say, we'll probably have to think about another medication for a rescue. But in general, I continue to use triptans for a lifetime as long as they have a fairly normal heart health.
You know, I was thinking about this one too. What is it? Are migraines just discomfort? Not minimizing it, I don't think, but do they actually cause damage?
Oh, that's a very good question.
Yeah.
And it's a question that we debate a lot. When we look at an MRI of somebody's brain with migraine, we often see little white dots in the brain. And we say, well, is that worrisome? Is that a problem? Could that represent white matter disease? And then maybe like 5 years later, we'll image that same person and those little white dots are gone, and maybe there's little white dots in a few other places in the brain. And that makes us say, what just happened? How can the white spots just move? And that makes us question what the white spots are in the brain. Are they signs of disease? We don't really think that they are signs of microvascular disease. So typically when we talk about white matter disease, we think that that's a risk for stroke. We think about risk factors like high blood pressure and diabetes and high cholesterol can cause white matter disease. But the white spots that we see in the brain for migraine patients don't seem to be the white matter disease that we're seeing for patients who are at risk of stroke. And we don't know what that is. So in general, we don't think that migraines are doing any damage to the brain. Now, there are isolated cases where we've seen patients have outside of the normal headaches, and maybe that can lead to some brain issues. But in general, the answer is it doesn't seem to. What can be problematic for the brain is depression. And sometimes in patients who have chronic migraines or have untreated migraines, it's not fun. It can cause depression, and that basically slows down the network and doesn't allow the network to fully function and can lead to problems in the brain.
So can you talk about, is it possible to have a full body migraine, pain that spreads to every joint or to your feet?
Yeah, I've seen that before. And I think what is happening in the brain is that you're getting a huge burst of hyperexcitability, and it's not just contained to the portion of the brain that represents our head. So we have a large sensory cortex. It represents all of our body, and oftentimes when we have pain in the arm, it will just stay localized in the arm. But sometimes we get so much hyperexcitability, the neurons get excited all over the brain. And so oftentimes when I get a patient in my office who has full body pain, I will start by tackling the migraine because we have such good treatment for migraine. And then we'll see where we get. And they may say, wow, since we started treating this migraine, my headaches are so much better, my body pain has improved, and now it's more focal. So now my body pain is really just focused in my knee or my lower back. And then we'll focus in on that part because it may be separate. There may be a separate issue going on. But I really prefer to start with the migraines when I get a patient who has chronic full body pain.
There's a lot of questions about auras. This says, I don't mind the headaches, but it's the aura that makes me incapable of doing normal things. Do these medications work to stop aura?
Yes. So that is a really a hot question right now. And there's a lot of the rescue medications that are trying to work on stopping aura. And so I think the earlier you take your rescue medication, the better off you're going to be. Even before the pain starts, the minute the aura starts, take the rescue medication. There are also some better preventive options for patients who have migraine with aura. Magnesium and Topamax and Depakote seem to be some of the better preventive options for patients who have migraine with aura, at least to start with.
I was perceiving an aura as a symptom or a part. Is it a separate thing, or are there two separate types of migraines, with and without?
Yeah. So about 30% of patients have migraine with aura. So not everybody gets an aura, and the aura can be particularly debilitating because it can disrupt your vision, it can disrupt your speech, it can disrupt your cognition. But many patients will say that their cognition is disrupted, and that premonitory period we were discussing is a period of time where a lot of patients just don't feel quite right, and they can't really put their finger on what it is. And so it makes us wonder if maybe everybody's experiencing aura in some way, and we just don't really understand it well enough yet. But aura is a period of quieting down. It's sort of like the calm before the storm. So we actually see a lot of decreased neuronal communication before we have the hyperexcitability of migraine.
Okay. This person's got another question about oral migraines. In menopause, she's been told she can't have estrogen since it makes her migraines worse or could potentially cause a stroke.
Okay.
So what are your thoughts about estrogen and aura migraines?
Yeah, I think that's a big, big myth.
Oh, good.
So I think that the reasons why you cannot have estrogen have to do with if you have a history of breast cancer, uterine cancer, endometrial cancer, and you maybe have a gene receptor issue, in which case estrogen is off limits because there's a concern that estrogen could cause cancer for you. Other than that, I think what we have learned about estrogen during menopause is that it is generally helpful, it is generally well tolerated, and I think if your doctor's telling you that you should not be on estrogen, you really need to ask why and what their thinking is. I have some patients that try estrogen and really don't like it and really think it disrupts their migraines. But in menopause, the hypothesis is that estrogen is kind of fluttering around all over the place, and the irregular estrogen is really creating headaches. And so if you put somebody on exogenous estrogen, it helps smooth out the estrogen and give you basically a calm, even level of estrogen throughout the month. And that is generally extremely helpful for patients with migraines. Does it increase stroke risk? If you have a lot of stroke risk factors, you may have a small chance of increased risk of stroke. If you don't have any stroke risk factors, if you do not have high blood pressure, if you do not have diabetes, if you don't smoke, if you don't have high cholesterol, if you're not overweight, then I think it's a reasonable discussion to have with your doctor about starting estrogen, and I do not think your risk of stroke is that great.
See if you've answered this one. I don't mind the headaches, but it's the aura that makes me incapable of doing normal things. So do medicines work to stop the aura?
Yeah, well, I think certain medicines can be more effective than others. So migraine prevention with a medication that is centrally acting, Topamax, Depakote being sort of the hallmark ones, but also tricyclic or an SNRI or an SSRI, all of those could help decrease the aura. There's also a gadget called eNeura, and it's an interesting gadget that is a handheld magnet. So it's a half Tesla magnet, and the idea is that you put it on the back of your head and it realigns neurons and normalizes the signaling of neurons. And they have some data that shows that they can be helpful for the aura portion of the headache. So you can use it right at the beginning to help normalize that signaling.
What about this? Are there ways to understand what your triggers are if you don't even know where to start?
Yeah. Well, it kind of depends on who you are as a person. So they have these things called trigger trackers, multiple different apps that will ask you a lot of questions, try to get an understanding of who you are and what your typical day is like and what you're eating and what you're doing and where you live and what the barometric pressure is where you live. And then they'll put all that information in for you and then correlate it to when you're having your headaches and try to help you understand your triggers. It's a lot of information to input on your part, and sometimes that can get a little bit exhausting. So if you're up for that, peruse the app world and you'll find numerous different programs that will help you with that. If that's not your speed, then I would say your energy is best spent in just trying to have as regular of a schedule as possible, because we know that regularity helps the brain run optimally. We're just like children. Children need to nap at a certain time. They need to eat at a certain time. They need to exercise, or else they get grumpy and their brains don't work so well. We're just the same. We need the same things. So if you want to spend your energy working on going to bed at the same time every night, waking up at the same time every morning, eating regular meals every day with high protein, low carbs, minimizing your caffeine, minimizing your alcohol, exercising, that's where I put my energy rather than trying to track my triggers.
Can changes in elevation and in particular flying trigger a migraine?
Yeah, well, I mean, certainly my patients have told me that. Mm-hmm. So in cases where flying reliably causes a migraine, we can try to prevent that by using a long-acting triptan. And so if you tell me that I always get a headache 1 hour after I take off on the airplane, then I would say we're going to put you on a long-acting triptan. You're going to take it an hour before you get on the plane, and it's going to stay in your system for 8 hours, and hopefully it's going to prevent or minimize that headache that you usually get on the airplane. Altitude's kind of hard because some people live at altitude. Mm-hmm. And I hear it both ways. I hear my patients move to California and they're at sea level and they start getting headaches, or they move to Colorado and they're at 5,000 feet and they start getting headaches. So yes, it can be a trigger, but it's very different for different people.
You've said a couple things about it being genetic. So is what triggers you a genetic thing?
I don't think so.
Okay.
I think that everybody has their own unique triggers.
Oh.
And part of the individual migraine journey is kind of figuring out, what's good for you and what's not good for you.
Yeah. Is it true that migraines that start happening during puberty for girls can go away once they reach adulthood?
So the most common pattern that we see for women is that headaches start around menarche, and they peak around the childbearing years, and then they taper at menopause. So good news for most women is that around menopause or shortly after menopause, most women's headaches go away, become much less intense, much less frequent.
Do we know why migraine affects women 3 times more than men?
think it has. We think it has something to do with estrogen. We think it has something to do with the way women process sensory information, and that's about as far as we've gotten, unfortunately. But women have more pain than other. I mean, in all areas of chronic pain, except for maybe a few isolated types of chronic pain, women experience it more than men, and that's sort of one of these things we're working hard to figure out.
Okay, I have had menstrual migraines with PMDD. They occur every month, a week before, and the first day of the menses. So what is the best approach to treat them?
Okay, they occur every week, the month.
Every month, a week before the period starts, I think.
Okay.
And then the first day, on the first day. So what's the best approach?
So the best approach would be to save your rescue medications for that week that you are having your migraine. So it sounds like it's maybe 7 days of migraine per month. And oftentimes we would say, all right, you're going to start your long-acting triptan on day 1, and you're going to take it every day for those 7 days of the month. And that's, so it's a triptan, which I previously told you was a rescue medication, but in this case, we're using it as a preventive medication for menstrual migraine.
There's a lot of creativity as you...
It's a little bit of creativity,
for people. Yeah. So there have been studies that show that veterans, as a community, have a higher likelihood of migraines. Are there environmental factors that you think might be contributing?
I'd have to look more into that. I don't work at the VA, so I don't often work with the veteran population, so I'm not sure I can answer that question authoritatively.
And a lot of people are saying that they do receive this regularly, so I think it's a good question. Do you have suggestions on how to handle chronic migraines and work demands? Yeah. It seems like just when I'm feeling better, I get another migraine, and it impacts my productivity.
Mm-hmm. I think that it is really good to work with your doctor to, again, try to continue to minimize those days that you're having migraine. It's also important to have your doctor write a note, maybe explaining to HR what's going on, so that HR is aware that, while you don't look like your head's not falling off and blood's not dripping out of your ear or anything, you are suffering. And oftentimes there's some pretty simple things that one can do in your office that can make the environment a lot better. For example, those bright overhead lights can be those fluorescent lights can be really hard for migraineurs. So sometimes like some actual outdoor lighting or some softer lighting can be really helpful. Being allowed to maybe not have to be on your computer for every meeting. Like sometimes you can just be listening without having to look at the screen and show your face can sometimes be helpful for migraine patients. Being able to have just a little more flexibility in your work schedule, because maybe you do need to go home and take your triptan and have an afternoon break, but then maybe you will feel better in the evening and be able to do your work in the evening. So I think most doctors that I work with in Silicon Valley have worked on trying to devise some work specifications or requests for a lot of patients so that they can maximize their productivity.
Is it bad to succumb to your food cravings when a migraine is coming on? Is that a symptom?
Food cravings? It actually is. So in the premonitory phase, many people will have food cravings for, I don't know, chocolate or who knows.
It's not going to be good for you, whatever it is.
Yeah. I mean, I guess if it had a lot of chemicals or preservatives in it, if it has a lot of MSG in it, if it has a lot of guck in it, it might not be the best to succumm to that. If you have a craving for an apple, I think that's probably okay.
Okay. I knew it. It just had to be true. What about this one? Is there any relevant research regarding the physiological response known colloquially as ASMR and its effect on migraines, or correlations between populations that experience ASMR and those that experience migraines?
I don't know what it is.
I don't either. Could you tell us what ASMR is?
Yeah,
You can just send it right back to the. So what's nice about being live?
Yes.
So here, while we look for that, I have had some vision disturbances randomly in grocery stores of all places since being in menopause. A lot of menopause questions, you know. It lasts only for 15 to 20 minutes, and sometimes I get a headache afterwards. My eye doctor said it's a visual migraine that is seen in women in this phase of life. Can you say more about migraines and menopause symptoms, perimenopausal symptoms, and maybe you should come back next month because we're going to have a whole thing about menopause.
Yeah, well, I mean, migraines change in menopause. So if you start having like brand new, like if you've never had headaches before, and then you go to menopause and you start having headaches, you need to go see a neurologist. You need to talk about it with a neurologist. That's something that we want to make sure we are not missing anything. But many times people's migraines will change. So you'll have this kind of set headache pattern, and then when you go through menopause, maybe things will be rocky during perimenopause when estrogen's kind of all over the place. But then when estrogen finally gets to a lower and steady level, oftentimes you'll get very few headaches. But they can be different. And so I think it's important to get it checked out if you have a new type of headache. This type of headache where you lose vision and then you get a migraine is sort of, sometimes eye doctors will call it ocular migraine. Sometimes people will just get the aura changes without getting the pain. And I think it can definitely happen, but it's good to talk about it with a doctor and just make sure that everything is under control. And sometimes we do need to treat it.
We have an answer, autonomous sensory meridian response. It's a tingling sensation that usually begins on the scalp and moves down the back of the neck and spine. And it says here, ASMR videos are getting popular because people will make the brain tickling audio and noises to comfort people. So now I got to go back and find that question. So are there any relevant research regarding the physiological response known as ASMR and its effect on migraines or correlations between populations who experience ASMR and those that experience migraines?
Well, it sounds like this person should come work with me in the lab and we can do a study on it and figure that out. Because I really don't know anything about ASMR, but it is an interesting idea that people who experience sensation differently might be in a different category of migraine.
Have you heard of a rebound migraine?
Yeah.
Okay, so somebody's saying, what can you help me with when I am stuck in a loop of migraines?
Yeah, I know. So that's where that occipital nerve block, or the trigger point injections, or the SPG block, or some of those devices might come in handy. Because what happens is sometimes you get in a cycle where you're having a migraine like 2, 3, 4 days in a row, and you start taking your triptan, and then you take it again, and then you take it again, and the third day maybe it doesn't work at all. I usually tell patients at that point in time to stop taking their rescue medications, stop their triptans, stop their Advil, stop their Excedrin, stop their Tylenol, whatever stuff they're taking, stop all that stuff, because what it may be doing is causing a rebound headache. And then that's when we kind of try to use a trick. Like sometimes we'll use a steroid pulse, sometimes we'll use a course of Depakote, sometimes we'll use an occipital nerve block, try to do something to kind of, again, disrupt this feedback loop.
Well, the last one I have here is fantastic talk. Thank you. So we wanted to get your closing comments because people have really participated and gotten a lot out of this. What do we walk away knowing?
Yeah, well, I really appreciate you guys listening today. Again, migraine is a really challenging condition that I think is under-recognized. It affects 1 in 10 Americans. And I think we sometimes say, oh, it's just a headache, and we kind of don't really treat it as to what it fully is, which is a very disruptive sensory experience that can be treated with lifestyle changes, preventive medications, and rescue medications. So I urge you to tell your friends and your family that they should come see us, and we can help them, and we want to help them.
Oh, thank you so much, Dr. Barad. Thanks again for coming back. And we'd like to say thanks to you for joining us. Through your company's partnership with Stanford Medicine, you get these webcasts and access to our full webinar library. So once again, if you missed any of today's webcast or you'd like to view it again or part 1, it'll be available on demand using the same link that got you here today. And so join us again for next month's webcast. As advertised, Dr. Karen Adams will be here on Things Your Mother Never Told You, navigating perimenopause and menopause. I'm Mary Windishar, and on behalf of Dr. Barad and our team here at Stanford, take good care and thank you for joining us.